Off mute? Yes. Good. I think I got the thumbs up. I got the thumbs up. So welcome to you who are here in person. This is the first time we've done in person in a couple of years, since 2019 when we were all in Anaheim. Several of us in this room were all in Anaheim together. This is the Neuroendocrine Tumor Patient Education Day, part of the annual meeting Patient Education Day. And I'm really fortunate to have a lot of great speakers from actually around the globe, from here in Canada and from Germany, as well as a patient experience from the United States as well. But first, and for those of you who are watching online, obviously you can ask questions if you're watching in the Slido interface. There's a question area. We will see the questions. When it comes time for questions, we will put the questions up on the screen so that everyone can join in. We are going to walk through all of our speakers first. We're going to try to get done by 3 o'clock so that I can take those patients who want to walk with me on the exhibit tour to go see the exhibit hall together. And that's it. And without further ado, I'm going to introduce Maj from CNETS Canada. Obviously, we're in Canada here, and Canada has a national patient group, actually more of a medical society that does a lot for both research and patient education. So I'm going to turn it over to you while we go for it. And you can just move your slides there.
All right, so hello everyone and welcome. My name is Maj Gadban. I am a board member at the Canadian Neuroendocrine Tumor Society, known as CNETS, and I'm going to give you a brief introduction to CNETS and the great work that we do. So CNETS is a national oncology patient organization providing support and education on all aspects of neuroendocrine tumors for people living in Canada. Our website is cnets.ca. Our priorities are support, including patient support and caregiver support, education, raising awareness, advocacy, including treatment access, and research. So for support groups, we have many support groups, including formal support groups, informal support groups, and we have online support groups. And we've got 2 groups in BC here, one in Vancouver and one in Victoria. Our website, which we maintain up to date, has resources. We have an email and telephone support line, which gets over 500 email and phone support inquiries per year. Our website, which gets about 3,500 views per month, and our NET reference guide, which is available on the website. Our education initiatives have included the 2021 Virtual NET Patient Conference with over 250 attendees, which included world-renowned experts in NETs across the country. And some information throughout the pandemic that we shared was this COVID-19 vaccine and NET cancer patient document. And this year we will be hosting our NET education webinars and Zebra Chat, which are a webinar series featuring inspirational Canadian neuroendocrine patients with an interactive Q&A. And also this year we will have our 2022 Canadian NET medical and scientific meeting. So awareness. Our awareness initiatives have included sharing patient stories in the media. We've collaborated with other national oncology patient organizations in Canada to raise awareness about neuroendocrine cancers. We've also supported the International Neuroendocrine Cancer Alliance campaign on knowing the symptoms and pushing for diagnosis. And every November 10th, it's NET Cancer Awareness Day, where landmarks across Canada are lit in zebra colors to raise awareness for neuroendocrine cancers, including this Vancouver Convention Center, which we are in today. And last but not least, we have our annual fundraiser, which is the Hoofing It campaign, where participants rack up kilometers either by running, cycling, walking, in order to raise money for neuroendocrine tumor research. And with that, thank you for your attention. If you want more information, visit the website, come talk to me, I'll be around, and there'll be handouts here and at the NorCal booth as well. Thank you.
So next up, and remember, virtually, please feel free to ask questions using our Slido interface. So it's really funny. It's not funny. Being diagnosed with a neuroendocrine tumor is obviously not funny. And in this time of the pandemic, many of us who run support groups are meeting people for the first time face to face. And I think Denny joined one of the support groups I run virtually, about 18 months ago, if I think correctly. And yesterday was the first time we met each other face to face, and he said, "You're much taller than you are in the screen." And it's really true. It's interesting being back around everyone. And I asked Denny here to give us a little bit of perspective of a patient that has gone through radionuclide therapy, a PRT, in the US, and I'm going to turn over to Denny for a few remarks.
Thanks, Josh. And yes, you are taller than I expected, but I'd been warned. Anyway, I'd like to think, here we are in Canada, so I thought maybe the reason Josh invited me here is because my NET specialist doctor is Canadian. And I thought, well, that's not the case. And I thought, well, maybe he found out my mother was raised on a wheat farm in Alberta, and then he'd never have that figured out. But anyway, it's probably because I live about an hour and a half south of here in Washington State, so we're close by. And that made it convenient for me to come up and have the chance to meet him. And it's an honor to be here and be part of this panel, so thanks, Josh, for asking me to come up and join you. A little bit about me first, just as an overview. I'm living with well-differentiated grade 3 midgut Ki-67 of 22.4% that was diagnosed in June of 2020. So I'm just about at my 2-year anniversary. I've got significant small lesions in my liver. My doc said it's probably somewhere between 50 and 100. So when I first had that diagnosis, it was a little bit frightening. I do have functional tumors, so I also have carcinoid heart disease. That came along for a bonus. And I get lanreotide injections every 4 weeks, and I also have gallstones now. So that came on as another bonus. So my journey was somewhat unique on this path to PRRT, in that my PRRT was actually my first-line treatment. And I found out pretty quickly after I'd been diagnosed and done a lot of research that is not the common treatment path. And for me, one of the questions Josh asked me is how did I get to that point in my treatment plan where that was the choice that was presented? And because of my grade 3 diagnosis and because of the extent of the disease, I do have one small tumor that's outside the liver in my mesentery. When I found Dr. Koenneke as my specialist, we talked about what might be possible for my treatment plan. Everolimus came up as a possibility, and PRRT came up as a possibility. And I'd done research on both, and because of the burden in my liver, I was very interested in something that might be able to reduce my tumor burden. And so we talked about it and decided, in my case, that would be a good option if I was game for it. And I said I was game for it, so away we went. And that was my PRRT treatment completed in March of 2021. So I'm about 15 months now with progression-free survival. And that's great. So what I found is that for me, the experience was pretty straightforward. And now that I've had my 1-year anniversary scans, kind of surprisingly, the response was good for me, and my tumors were still reducing in size a year after the PRRT completed. The most important thing was my quality of life has been just incredible. the symptoms that I had going into this, I had flushing, I had weight loss, I had a little bit of GI distress. After the second PRRT treatment, my symptoms went to 0 and they haven't come back. I had weight loss. The two things that started me on the path to knowing something was wrong was flushing and unexpected weight loss. And so by the second PRRT treatment, my weight loss had quit. And I started to be able to gain weight again until eventually today I've gained all the weight back. I have had no reoccurrence of any symptoms. And what is just amazing to me is I feel 100% normal. All of my daily activities have gotten back to 100% normal. My stamina is 100% normal. Actually, it might be even a little better than it was because I work out a lot and stay very physically active. So as far as the treatments themselves, they went very easy for me. I had a little bit after the first treatment, but after that, it was just really kind of no issue. Get a treatment, go home, go back to normal. So my experience with PRRT, it was a game changer for me and for someone that felt like they were on a very serious path. I'm back to normal, and I'm grateful.
Thank you, Danny. Now let's see, I should just keep ducking because every time that I do this, they have to then readjust for me, but that's okay. Our next speaker, and I think I have this one right. Yes, I do. Dr. Simran Singh, who was with us earlier today talking about clinical trial design and the ideas behind clinical trials for patients, is also an oncologist at Sunnybrook at the University of Toronto, and really was was the co-chair of the clinical trials planning meeting that was looking at what do we do next at the NCI in the role of, in this world of clinical trials post-PRT. And without wasting much more time, I'm just going to turn it over to Dr. Singh.
Thank you. Thank you, Josh. And thank you very much for sharing your story. I think it was very inspiring, and I think it's going to fit in very nicely to contextualize. So thank you for sharing with us. As Josh mentioned, I'm a medical oncologist. These are my disclosures. But I do have a disclaimer, and I'm going to talk a little bit about PRT, and we have Dr. Baum here. Obviously, as a medical oncologist, my interpretation and my understanding of PRT is going to be slightly different. And so I'm going to talk to you about how I see PRT as a medical oncologist and what lens I see that through. So, this idea of PRT is really revolutionary in the cancer world now. You can see that there's growing in many different areas, even outside of neuroendocrine. And I think it's we're quite proud of the fact that, we have a lot that we can help other patients with and teach the experience that you just described, that other patients, other diseases will start moving forward, such as prostate cancer, et cetera. So I do spend some time now teaching our medical oncology residents at the University of Toronto about this therapy, and it really comes down to how do we think about it? There's many ways to think about it. Is this molecular therapy? Is it internal radiation therapy? Is it systemic radiation therapy? Is it really systemic therapy? At our center, we give it in the chemotherapy unit, in the systemic therapy unit. Is it radiopharmaceutical therapy? So different words, and it really means the same thing, but it's such a unique way of treatment now that it's really the new era of truly personalized medicine in neuroendocrines. So as a medical oncologist who's working on neuroendocrine tumors, what questions come up to me? It's about when do I use systemic therapy versus PRT? And what is the sequencing like? And who are the right patients for whom systemic therapy might be beneficial? And who are the right patients where PRT may be beneficial? Is there promise for combination therapy? Does it work? Is it safe? And then how do I treat a patient after they've had PRT? What are the next steps in care? So this is how the questions that come up in clinic in our medical oncology approach. Excuse me. So what really matters? And I think one of the center approaches we have to take is a patient-centered point of view. And what we really need to understand is, for our patients, as a medical practitioner, we need to continue to understand this is a continuous journey. Our system sometimes is designed in what I would say episodic care. The system is designed for people to come, get care, and then go home. But really, as we just heard, cancer is a continuous journey. It doesn't stop when you leave the cancer center. It doesn't start when you enter the door. And so we need to start thinking of treatments that potentially can help people deal with this disease more in a long-term, continuous fashion. We know that many patients will live with this disease for a long time, and so we talk about this to try to turn this into a chronic disease or a chronic cancer. But we also need to determine what's important. What are our patients hoping to achieve, and then what tools do we have to achieve that? How can we use the tools that we have currently to meet people's goals? These are all real patients. The pictures obviously aren't real, but I had a patient who had a disease and really told me that I want to make sure I'm there for my daughter's wedding next year. I want to be able to walk her down the aisle, and we were able to work towards that, recognizing that was his biggest priority in his treatment. This was another gentleman, again, not the real picture obviously, but I had a gentleman who, when we talked about how this disease was impacting him, broke out crying. And he said when his son was young, when he was young, his father used to take him to hockey games and watch him play hockey. And he was in tears that he couldn't take his son because he had bad carcinoid syndrome and he had problems with bowel incontinence, and he was having accidents and he couldn't make it fast enough. And so we were able to work on symptom control for him to be able to take his son to hockey games, and that was really meaningful for him. And of course, then we have people who want to travel. They want to maintain a good quality of life. They've retired and they want to be able to travel with their partner despite having this disease, and so travel is very important to them. So these are all real patients, but slightly different approaches given the different preferences that patients may have, or at least the different priorities, I should say. So when do I use systemic therapy versus PRT? So this was through the SNMMI, but with NANETS. We did a consensus statement to try to think about when PRT would be useful. Clearly, we thought about disease progression after first-line and somatostatin analogs, and this would be reflective of our Canadian practice currently, where patients generally use somatostatin analogs first and then would progress to PRT. Patients in first line, where there's high tumor burden, where we think any further growth would get significant risk, and as much as you were just discussing this idea of reducing tumor burden, this isn't always reimbursed, and this can be a challenge in Canada to get reimbursement in these sort of unique situations, but we're working towards it. Patients with midgut nets, if they're SSTR positive, if they're functioning, and we need to try to get symptom control, we can often use that. And then, of course, pancreatic nets, although we do need to take into account that there are other treatments, and especially in recent weeks, we've even heard more and more data about that. These are the European guidelines, and you'll see here that the European guidelines talk about PRT after somatostatin analogs, as well as maybe earlier on in the G3 neuroendocrine tumors. Now, in Canada, we have a public healthcare system, but we do have different provinces that run the healthcare system. So the reimbursement system is somewhat different across the country. In most provinces, we can get PRT or PRT close to the province. In the case of the smaller provinces, for the midgut tumors, the pancreas tumors, it's slightly variable, but that's a changing landscape altogether. So part of this depends on what's right for the patient when we think about PRT, and then part of it's right of what we can actually get from reimbursement and the regulatory authorities based on where you are. So how do we make decisions? Well, we heard about everolimus. This is one of the treatments that we've been using previously. This was the Radiant-4 trial, which looked at patients who had non-functioning GI or lung nets. This was a G1, G2 population, so a slightly lower grade, well-differentiated population. This was a clinical trial that randomized people to 10 milligrams of everolimus versus placebo. And as you can see here, progression-free survival, this was a very efficacious treatment with a hazard ratio of 0.48. Soon after, we saw the NETTER-1 trial published in the New England Journal, and this was, I think most people are aware, these are patients who had midgut neuroendocrine tumors who had progressed after standard dose of somatostatin analog therapy and were then randomized to receive either 4 cycles of PRT with maintenance octreotide or high-dose octreotide. And the results of this were pretty phenomenal. This was the groundbreaking study that really opened our doors in Canada for us to be able to offer PRT. We knew of this treatment and we were very excited about it, but it was after this trial that we were able to make progress and get this offered more widespread across the country. When we look at the overall survival now of NETTER-1, the new survival, it does not meet significance, but I would caution that we should think about that carefully, given that there's been crossover as well as been subsequent therapies. I think regardless, what we really know is that PRT is a very effective therapy for many neuroendocrine patients, especially the midgut patients. What do we know about the pancreas neuroendocrine tumors? We have less prospective data. We have good retrospective experience, understanding that there appears to be actually a very good overall response rate to PRT, maybe even higher than midgut neuroendocrine tumors. We have the COMPETE trial, which is letting us, getting, I think it might be complete or close to completion, looking at everolimus versus PRT. We did not have this trial open in Canada, but nonetheless, we look forward to the results. And then we have the Sequitur trial run by ENETS, which looked at streptozocin-based chemotherapy versus PRT, and again, we're waiting for the results of that. There is the NETTER-R study, which looked at, it was a retrospective survey of 110 patients who had SSTR-positive PNETs treated with lutetium dotatate. Again, although this wasn't a randomized trial, we did see very good response rates, as well as what we call a progression-free survival. So it does appear for pancreas neuroendocrine tumors, there's good promise for PRT as well. And again, depending on the different health systems in Canada or the different province, in some situations, this is already reimbursed and available currently. The other thing to consider when we think about pancreatic neuroendocrine tumors is chemotherapy. These are the updated data that my good friend Pam Kunz just shared with us, that at ASCO this year, this was a study done by the cooperative group looking at temozolomide and temozolomide with capecitabine in patients with pancreatic neuroendocrine tumor. And what we did see here, that the combination of capecitabine and temozolomide was not only superior to temozolomide on own, but had a significant or a meaningful PFS of 22.7 months. Again, like most neuroendocrine studies, they did not reach the overall survival endpoint, but at the same time, we recognize that because people are on many subsequent therapies, it's difficult to tell. And then the other neuroendocrine tumor that I see is lung neuroendocrine tumors, bronchial neuroendocrine tumors. We probably have the least amount of data here in terms of the role of PRT for lung neuroendocrine tumors. We are challenged with, we still have not all patients express SSTR, the receptors required for PRT with lung neuroendocrine tumors. So we look forward to this trial by Tom Hope from UCSF, which is another intergroup trial by our NCI collaboration, which is looking at the role of PRT in lung neuroendocrine tumors versus everolimus, which is currently our standard of care. One other trial we wait the results on is the NETTER-2 trial, which is ongoing, and this actually looks at well-differentiated neuroendocrine tumors, but with a higher Ki-67, so high grade 2 or low grade 3, and this is randomizing patients to first-line PRT versus 60 milligrams of octreotide, the same control arm used in the NETTER-1 trial. And again, this is will give us more information, just like we heard, about using PRT upfront, and for some patients, it may be the right treatment to do first. So a lot of options, I think, that we are continuing to explore, and a lot of data that will be coming forward that'll help us really optimize who should be getting PRT and when. Right now, we don't have a lot of data on combination therapy. We do have some Australian data, which does show that it maybe adds some toxicity, but not necessarily a huge amount of benefit from overall survival or a progression point of view. And part of that might be that we can use chemotherapy and PRT in sequence versus in combination, but I don't know if we have answers to this yet. We've also talked about immunotherapy, which has revolutionized much of the cancer world. Unfortunately, in neuroendocrine cancers, we haven't really seen a benefit of immunotherapy just quite yet, but there is data that will hopefully come forward that'll show us the synergistic effects of immunotherapy plus PRT, and as well, we don't know what the role might be for poorly differentiated neuroendocrine carcinomas, which are a bit more like small cell. So a lot of questions. I think I hopefully started with you to tell you that there's a lot of promise with radioisotope therapy in neuroendocrine cancers, but there's as many questions. So what can we use to help predict? How can we really center our care around patients and make sure that we individualize care as much as we can? There's different things that are coming forward. We're getting more data on the NET test and the PPQ, which is a liquid biopsy that helps determine who exactly would benefit from PRT and may be able to tell us early about who the people are that would benefit from PRT and maybe are the ones we should move up the arsenal. We also have something called the Net PET score. This was started by my fellow who worked with us here. It's Sunnybrook in Toronto for 2 years, David Chan, who's now running a PRT program in Australia. This looks at looking at traditional Fdg PET scans and a Gallium-68 DOTA scan and trying to understand how we can look at the relative uptake on these scans, again, to individualize care. Again, these are both promising ways in the future where we can potentially individualize care. Looking at PRT and the predictive factors, how can we determine who might respond? Again, we need to take the person and think of all the different factors that are related. What are the clinical factors that are related? The tumor sites I talked about, midgut, pancreas, and lung, we have different levels of data to understand how PRT might work. But of course, tumor burden and bulk of disease may also play a point. We don't know how the relationship is between SSTR expression and the response to PRT. That continues to be an ongoing interesting question. Is there other molecular profiling that we can do, like we're doing in other cancers, to try to understand a little bit more about these tumors? One of the new areas is tumor growth rate, looking at the speed of growth of the tumor to try to understand if potentially that might be a differing factor that we can individualize therapy for, as well as other novel parameters like radiomics, using artificial intelligence and looking at radiology scans to try to see on a mass scale if we can use artificial intelligence to help predict what treatment might be better for what patient at what time. A lot of this is done through the NCTN, and the NCTN is a collaboration in Canada and a number of cooperative groups in the United States to try to do these trials and try to get these questions working together as a team. Right now, we have some really interesting trials that are moving forward. We have our first ever adjuvant neuroendocrine cancer trial, which looks at the chemotherapy I described to you that we know is effective in pancreatic cancer. And this trial would look at, is it possible to prevent recurrence for people who've had surgery? There's a large trial that's ongoing. It's not open in Canada, unfortunately, but it's in many sites in the United States, which is the CABINET trial, looking at cabozantinib in neuroendocrine tumors of both the GI and lung origin. We are looking at, there's a new trial that's coming forward at this time, looking at first-line therapy of, comparative therapy of PRT versus capecitabine and temozolomide. I think this is going to be a very important trial run by Tim Hobday and Helena Soares. That's going to help answer the question of chemotherapy versus PRT for our pancreas patients, and hopefully, again, identify which treatment is right for which patients. We also have a trial that is going to be led by CCTG, which is our Canadian clinical trials group, looking at retreatment of PRT and to see what that's going to look like. So I think this is a very promising time in terms of where we're going. As Josh mentioned, I just want to mention that we did have, the NCI had a clinical trials planning meeting last year. This was done virtually due to the COVID pandemic, unfortunately. But what we wanted to do was really set the course of the next decade or so of PRT trials to try to understand what are the important questions and what do we really need to answer. And these are some of the themes that came out, which were retreatment with PRT. And as I mentioned, we have now an approved trial that's going to be launched looking at retreatment with PRT. So people who've had PRT once, if they have a good response, can we retreat with them? What about immunotherapy and PRT? As I mentioned, can we combine them together and potentially improve the role of immunotherapy? Combination therapy with PRT, is there other treatments that we should be using? We looked at chemotherapy, but what about other agents that damage DNA or cause DNA damage repair? Liver-directed therapy, is there a way to integrate PRT into the treatment paradigm for people who have very heavy disease in the liver as opposed to other parts of their body? And what about people who are PRT resistant, who PRT doesn't work? Is there a way of inducing sensitivity to PRT? Meaning, for patients who PRT doesn't work, can we do something else that will help make PRT work, or is there other things we should do? So I think there's a lot of questions to move forward, but I think overall it's a very exciting time. This therapy has really opened the doors, and as a medical oncologist, I continue to try to figure out these questions and as much as we can individualize our treatment case as much as possible. So I'll stop there and thank you very much. Questions now or at the end? Now, questions or at the end?
No, at the end.
Yeah.
Okay, the whole panel. Time for me to duck down again. I won't be up here long. You don't have to do too much here. Our next speaker is Dr. Rebecca Wong from also from the University of Toronto, and she's going to talk about radiotherapy and imaging of neuroendocrine tumors. So I'm just going to turn it right over to you. It's good to see you after all this time, not being on Zoom as well.
Thank you. Good afternoon, everyone. It's a great pleasure to be here with you. Here are my disclosures. So Josh gave me 2 questions to look at, the role of radiotherapy in neuroendocrine tumor and the role of imaging in the treatment, decision-making, and response assessment for neuroendocrine tumors. As a radiation oncologist, we look at the role of external beam radiotherapy, which is what I'm going to be focusing on for the first half of the talk, in 4 buckets: to provide palliation, relief of symptoms that patients are having currently or is about to have, improve local control to prevent the disease recurring in a particular area that we can see it, irrespective of whether it progresses elsewhere. Usually for areas it is in a critical location where local control is important. Use it in adjunct with surgery, preoperatively, postoperatively, or use as a primary modality to cure cancer. In general terms, for palliation, we try to give the lowest dose possible that will relieve the symptoms, avoiding toxicities. And at the other end of the spectrum, we give the highest dose possible when we're trying to cure, either in combination with chemotherapy or on its own, trying to maximize the likelihood of achieving cure, eradicating all cancer cells possible. In the middle, for local control or for as an adjunct to surgery, we use an intermediate, usually intermediate to high dose that focuses on avoiding toxicities and minimizing toxicities when it's used in combination with other modalities. In contrast to most solid tumors, the use of external beam radiotherapy in neuroendocrine tumors tend to be focused in the area of palliation. As summarized in this guideline that was produced by the North American Neuroendocrine Tumor Group, consensus guideline in 2020, written for pancreatic neuroendocrine tumors, but the principles generally applies across neuroendocrine tumor irrespective of sites of origin. After reviewing the data and consensus recommendation, the conclusion statement is that the data does not support the routine use of radiation with or without chemotherapy in an adjuvant setting, but does support it for the use of palliation and highlighting symptom improvement, especially for bone metastases. Why is it different with neuroendocrine tumor compared with other solid tumors? And the 2 biggest reasons is the degree of radioresistance that is perceived in this disease and the pattern of recurrent disease that tends to be diffuse in the long run, making it more difficult to pinpoint which area is going to benefit from more aggressive local therapy. What I do want to put forward, though, is that there are significant technological changes that may be shifting this paradigm going forward. And I would highlight 3 major areas that is perhaps going to be changing now, how we're thinking about it, and going forward. First of all, we have improved staging, and specifically we're talking about the generalized availability of Gallium-68 PET scan that allow us to pick up small volumes of difficult-to-see metastatic disease, and to really know who have localized disease and who have oligometastases, small volume of metastatic disease that will benefit from definitive therapy to the primary and the metastases, and those who would not and would benefit from more systemic strategies. Secondly, there is significant improvement in the radiotherapy techniques that we have, and this allows us to really target the tumor while sparing surrounding normal tissues, be it a long course of treatment, and specifically in the use of stereotactic radiotherapy over a few treatments that deliver tumoricidal doses that is now within our armamentarium of tools available. Thirdly, there is a growing evidence body of literature around stereotactic radiotherapy and its role in oligometastases and oligoprogression. It's less studied area, specifically in neuroendocrine tumor, but one would argue that given the long trajectory of the natural history of well-differentiated neuroendocrine tumor, in this disease, it is most likely that we have the window of opportunity to identify patients with oligometastases and would benefit from more aggressive local treatment for their metastases. The body of literature is emerging, and this is a series that is published by the Sunnybrook Group, looking at a retrospective review of their data using SBRT for liver metastases. They were able to demonstrate a high local control rate of 92%. Progression-free survival is more modest at 44%, and very favorable toxicity profile, as we typically would expect with the mature implementation of SBRT. It takes a while for this treatment to work. The time to best response is about 9 months. It's a useful tool, and I think we should consider using it, although the million-dollar question is who is better to select for this treatment, both in terms for oligometastases and for patients who have multiple metastases, that they're dominant metastases that may benefit from local control. Here is a collection of cases that illustrate common indications as well as less common things that I think we should think about. In the left top panel is a patient with bone metastases, painful, and patient is recommended to have 20 gray and 5 fractions, which is a very standard way of treating bone metastases, and the patient had good pain response that is quite durable in this case. The bottom left panel demonstrates a patient with a soft tissue metastases at the back of his neck. It was bothering him, and we gave him a single 8 gray, and he got partial response for more than a year. The panel on the right is a less common scenario that I think we should start thinking about more frequently. This is a patient who, back in 2005, was diagnosed with a functional paraganglioma that was resected. She recurred 6 years later in a tumor bed area, presenting with labile hypertension consistent with a functional tumor. Because of the location, making it difficult to consider resection, as well as the emerging of small volume liver metastases, surgery was not pursued. She had labile hypertension for many years. There was an attempt to use Sutent to control her disease and symptoms, but it wasn't very effective. And I got to see her for consideration of PRT. We actually accepted her into our Ontario trial at the time and gave her the first cycle, which actually triggered her hypertension, but we were brave and brought her in for the second cycle. And even as we were giving her the pre-medication, she developed a hypertension crisis that was difficult to control and required an ICU admission. So we aborted that plan. She really doesn't have a lot of other treatment options. So we offered her radiotherapy using a VMAT technique, delivering 30 gray and 10 fractions. The volume, as you can see here, is relatively large adjacent to other critical structures, limiting the dose that we could give, but it was quite effective. Her blood pressure settled down, her blood pressure medications was able to be reduced together with a biochemical response that is documented. She did ask me, why did we not do this earlier? And in my mind, I also asked myself the question, could we have given a higher dose and durable response? It's over a year now, she remains well. Just to demonstrate that there are some patients who, even though with metastatic disease, may have dominant metastases or recurrence that would benefit from more aggressive local therapy that we can now deliver safely. Data definitely needs to be more mature with longer-term follow-up and to better define who we should select for these treatment options. But in the meantime, multidisciplinary tumor boards with radiation oncologists who are interested in this space and prospective outcome registry is definitely the way to move forward. Switching gear to role of imaging in neuroendocrine tumors. The message that I want to pass on today is that there are many tools. These are you're familiar with, cross-sectional imaging with CT, MRI, and of course, PET scans, both Gallium-68 and Fdg that we'll talk about a little more, and the use of SPECT scans. Different tools for different tasks. The indications for these imaging is for diagnosis, treatment decision-making, evaluation of response, and evaluation of radiation dose absorbed. We all know what CT scan is, but just for completeness, just to highlight that usually is performed with oral contrast and IV contrast to allow best delineation of normal tissues as well as tumor. The enhancement pattern is best interpreted based on imaging patterns, especially with contrast. You might hear about biphasic and triphasic images, especially for liver, which allows better delineation of the extent of tumor. It's really good for problem solving for certain abnormalities such as a cyst versus metastases that is demonstrated here. Magnetic resonance imaging is typically performed for individual body parts as opposed to total body. And in the reports, you will hear about T1, T2, DWI, many different types of imaging the same body part with different enhancement pattern. And the radiologist will look at all of these information to provide an overall interpretation of what abnormalities are. The IV contrast used is gadolinium. I will also mention about the Primovis IV contrast, which is particularly useful to looking at liver lesions to distinguish tumor versus other benign entities. It's marvelous for anatomical details, and in the bottom panel you can see bony metastases pressing on the spinal cord, which you can't see with any other modalities with the same degree of resolution. Of course, positron emission tomography is the game changer for the management of neuroendocrine patients. It provides superior spatial resolution, and because of the way that the positron interact with electrons emitting two opposite gamma rays, it allows very accurate delineation of where that emission comes from, and therefore localization of the abnormality. The tracer that is used, of course, is Gallium-68, which is designed to target somatostatin receptors. And Fdg PET, which targets metabolic activity, also has a role for problem solving. Gallium-68 dotatate scan has lots of evidence behind it that shows that there's superior in performance when compared with other somatostatin tracers. And also other imaging modalities such as CT and MR, with a high accuracy rate of 86 to 97%. The image at the bottom just shows the clear distinction of superiority within Gallium-68 compared with the Odo-Actyl scan, for example. The key question is, when should Gallium-68 PET scan be used? It is wonderful to show the distribution of disease. And this is a systematic review that we conducted for the province of Ontario to answer that question. From a policy decision-making perspective, looking at the impact on patient care is really important to decide when is the best time to use these tools, especially given the limitations of access and the resource limitation and the burden on the patient. In this review, we found that overall change of management occurred in about 45% of patients that are selected for this treatment. It's particularly useful when we want to use it to decide on surgical planning, to decide whether there is metastatic disease that radical surgery should not be performed, or to identify small volume disease so that they can be managed together with the primary surgery, for example. It's also very useful, of course, for the selection of patients for PRRT, patients who actually have overexpression of somatostatin receptors that will benefit from this treatment modality. However, the search of evidence did not find that there is an advantage of PRRT over CT scans for assessing response, and there's insufficient data really to show that it's a useful tool for routine surveillance. as a result of these interpretation of the data, these are just some of the written guidelines for recommendation of when to use gallium-68 PET, at least in Ontario. I want to share a few examples to show how it may be useful. With Mr. A, he was diagnosed presenting with rectal cancer and found to have this rectal mass. And it shows a neuroendocrine tumor, and standard cross-sectional imaging did not show any metastatic disease. Before the patient went on to surgery, a gallium-68 PET scan was performed, and it was negative. So the use of this scan was able to demonstrate that it is confirmed the decision plan to go ahead with radical surgery for this patient with a chance of cure. Meet Ms. Z. The gallium-68 PET scan in this case was used to understand heterogeneity of the disease, of her metastatic disease, and eligibility for PRRT. It's a patient with pancreatic neuroendocrine tumor with no metastases to the liver, lymph nodes, and lung, with a Ki67 index of 20%. The gallium-68 PET scan on the left demonstrates the high uptake in the bottom panel in the mesenteric lymphadenopathy, the middle in a small lung nodule. But on the top panel, it shows the supraclavicular nodes have a faint uptake. It's a sizable lesion. The question there is, could this conglomerate of disease be harboring higher grade disease that is going to be resistant to PRT and lead to failure? As a result of that observation, an Fdg scan was requested, and the results are shown in the right panel. In this case, the tumor did not pick up Fdg in any of these locations, confirming to us that there is no significant heterogeneity of high-grade disease, and therefore PRT is suitable. In contrast, Ms. K also had a gallium-68 scan to understand the heterogeneity of the disease and eligibility of PRT. In this case, the patient is known to have liver, nodal, lung, as well as suggestion of bone metastases. In the gallium-68 PET scan, there's faint uptake in the bone, on the rib, and in the spine, again, raising the concerns as the previous patient. So an Fdg scan was performed. Here it shows intense uptake in the bony metastases, suggesting that the disease here is more likely higher grade disease and therefore less likely to respond to PRT. In this situation, the patient was recommended not to have PRT and move for other systemic options. Imaging can be very helpful in individualized dosimetry, evaluating radiotherapy dose absorbed. And here, gamma cameras are used to image the patient after the treatment, and you can qualitatively see if the tumor is responding, but more importantly, that it's not progressing elsewhere, and that continuing of the PRT over the several months of treatment is appropriate. Individualized dosimetry, it usually involves performing these scans at a few time points after the injection, allowing us to plot the curves on the right panel, and the area under the curve basically gives us the radiation dose absorbed by the normal tissues, in particular the kidney, the bone marrow, and suitably calibrated and acquired. It can also tell us the dose that is absorbed by the tumor. Individualized dosimetry is not required with Lutetium, which is the currently available commercial product, and it makes it easy to deliver. However, I think in going forward, performing these SPECT scans with suitable standardization would allow us to understand the dose that is being absorbed by normal tissues. And potentially, a very active area of investigation is whether we can look at the tumor dose absorbed and adjust the dose and treatment schedule for these patients. For patients who respond well, can we dial back the dose? For patients who is not absorbing as much dose, can we give more treatment and safely do so within the limits of normal tissues? I think with all these modalities that are available to us, we're going to see more and more of these need to understand quantitatively what's happening to the normal tissues and the tumor. This is an example of a patient that had been living with unknown primary and has had all the available systemic therapy, and I treated him with PRT in 2016. We had a wonderful response comparing to the top panel and the bottom panel, and it lasted for 4 years. He then progressed in the liver, and I gave him SBRT. So this is a good chunk of the liver that received the treatment, and he progressed again in 2022. Can we challenge him again with PRT? Can he be treated with Y90 safely, another form of radiotherapy? We can eyeball it, but it would be much better if we can actually quantify the risks. So my take-home message to you is that radiation, external beam radiotherapy, is well recognized to be useful in palliation, but modern radiotherapy techniques such as FBRT can expand the indication for radiotherapy and require clinical trials to actually establish it and how to combine with systemic therapy, including PRT. Imaging, cross-sectional imaging, PET scan and SPECT scans are all useful at different stages of the disease and applications. PET scans are well recognized and supported by data for diagnosis, staging, and problem solving with less evidence for its routine use as surveillance and our response assessment. Thank you for your attention.
Our last speaker for this session promised me he only had a few slides, and I see slide 1 out of 110, but I know he's only going to show a few of them. And with that, I would like to introduce a very good friend of mine, Dr. Richard Baum, who's now at the clinic in, well, he's the chairman of ICPO. Actually, if I list all the things he's part of, it will take longer than his presentation. But interestingly enough, which I think he'll bring up, we actually met in Canada over a decade ago. So with that, I'll introduce Dr. Richard Baum.
Yeah, thank you, Josh. It's a pleasure to meet in person here. So there are not too many persons in the room, but I think there are many online. And 3 years, we had not the opportunity to have personal meetings, but we saw in between quite frequently. And before I start my presentation, I would like to come back what you mentioned. I think it was in Toronto in 2008, where Sandy McEwen organized a conference and where we first met. And I will not forget Sandy because I had a very good relation actually to Alberta and to Edmonton, where one of my very best friends in the early times when we did studies with monoclonal antibodies, namely Tony Nushaim, was working, and unfortunately he died of pancreatic cancer, but not neuroendocrine, right? But adenocarcinoma. Okay, I would just like to remind you that the best theranostic to date is still radioiodine, and this is where we have to come to in the future. These are slides from Michael Hoffman showing quite impressively that if you do iodine-124 PET, you get uptake up to 960 SUV, right? In neuroendocrine tumors, we are usually speaking about 30 as high or 40 something, so 20-fold higher. And you also have a very good retention time. So if you work with iodine-131, which is quite similar to lutetium in energy and effect on tumor cells, you can really cure people. And this is still our aim after more than 30 years, not only to reduce a disease or to stabilize a disease, but maybe to cure the disease. And one way to do that, you all know these slides on theranostic, using PET-CT for defining the appropriate patient population for therapy. Now not only in neuroendocrine tumors and PSMA, but also in the tumor microenvironment, which I will mention at the end of my lecture, targeting the cancer-associated fibroblasts. And don't forget the antibodies, right? They are still not frequently used anymore, only for a small indication in radioimmunotherapy of lymphoma. But I think there are many, many antibodies which are on the horizon which could be used. And then, that's why I show this slide, there are also a number of new radioisotopes for imaging, like long-lived radioisotopes like terbium-152, which we were using first in the world, which has a 16-hour half-life, but also scandium-44, which is a very nice imaging agent with a 3.4-hour half-life. And also, if you look at the cytotoxic unit, we have new alpha emitters like actinium and quite recently lead, but also on the horizon terbium radioisotopes, copper, and scandium-47. So there is still a lot of potential to improve our therapies. And because it's 25 years ago, in 1997, when I treated the first patient, nearly to the day, in July 1997, when we started in Germany with Prt and yttrium. And when I left my previous center in Bad Berka, we had performed actually more than 4,300 treatments with lutetium and more than 1,800 with yttrium-90. And we have published this data. Most of the patients were, of course, neuroendocrine tumors from the small bowel, but also pancreatic group was the second largest. And then 38 different kind of tumors we treated expressing somatostatin receptors. This is just one case showing that we really can get long-term effects, 70-year-old patients with a well-differentiated non-functioning neuroendocrine neoplasm of the rectum. So quite similar to the case the previous speaker has shown with large liver metastases in both lobes. We treated him with 3 cycles, and after, as you can see, 10 years, the liver is still free of disease. There is still some mild uptake in the primary tumor, but not bothering the patient in any way. So we can get long-term results. And again, we published a series of more than 1,000 patients with neuroendocrine neoplasms. And finally, the landmark study in the New England Journal, which was discussed by Dr. Simron here. And you see that led to the FDA approval. And I will give you a very short insight in new developments in neuroendocrine tumors. You were mentioning already the intraarterial route, which is one way to improve efficacy. Treatment of G3, NEN, also antagonists like LM3, LM4, JI11, and so on. I do not have the time to discuss all that, but just to mention it. And then, of course, alpha emitters. So what is the advantage of these alpha emitters? So the alpha emitters have a so-called LET, or linear energy transfer, 100 times greater than beta. Or to say it very easily, it's like you throw an atomic bomb on a small village. So if an alpha hits a cancer cell or the DNA of a cancer cell, it dies. There is no weapon to fight against this alpha radiation, whereas beta, lutetium, for example, or yttrium-90, make mostly single-strand breaks of the DNA, and that can be, in some cases, repaired. So it's not necessarily a totally lethal weapon. But alphas, if they hit the tumor cells, they cannot, overcome this with resistance. And the first treatments were done at the German Cancer Center, the Research Cancer Center in Heidelberg, already in 2012, the image of the year was shown with bismuth 213, which is part of the actinium chain, actually, when it decays. And you can see that this was the patient with hypervascularized liver metastases resistant to yttrium-90, okay, but with a few injections of bismuth, all the liver lesions were gone. We had treated in Bad Berka 45 patients and have analyzed them, and I will just show you a few examples here. A patient with liver metastases which were not anymore responding to lutetium, as you can see on the left, in January 2016 and 17, and then treatment with lutetium because the patient was progressive, but it further progressed in the liver. Even under yttrium, there was progression of the liver metastases, and then we just actually used actinium 2 cycles with a moderate dose, and you see that there is very good response here in this patient with very large liver metastases. And then I want to mention the study by Dr. Del Paso from Houston, Texas, who treated recently patients with lead-212 called dotamtate. So it's actually the same key like dotatate, but a different chelator used for keeping the actinium bound to the peptide. And you see that the doses were relatively moderate, 2.5 megabecquerel per kilogram, and there were really dramatic responses, like in this patient with widespread metastases in the bone, in the liver, and after 4 cycles using lead-212, there was complete remission of the disease. And this is why I showed in the beginning iodine-131 as a possible cure for patients with neuroendocrine metastases. And this is one example where you could achieve at least complete remission. If it is cure, we will know maybe in some years. And we also have, of course, to keep adverse effects in mind. We have now 25 years experience with Prt, so I do not understand why there is still the question of nephrotoxicity. Have you seen any patient with nephrotoxicity after lutetium? I have done 4,000 treatments and never have seen one. Right? You can even treat under dialysis. We have given lutetium, right? So this is just a question the FDA always asks, but after 25 years of experience, you should not anymore ask if lutetium is nephrotoxic. It is just not nephrotoxic, point, right? And the data are there to show this. And the alpha, as you can see here, even in patients on the right lower image with extensive liver metastases, there were quite a good response. So there is a clinical trial now starting on that, and the first, the last new development I will show here is treatment with FAP, right, which targets the cancer-associated fibroblasts, and we used it in many different patients. This is a patient with breast cancer, with widespread disease in the bone, and this made it to the cover of the Journal of Nuclear Medicine. And if you look at our patient data table, you see there are 3 patients with neuroendocrine tumors, right? Of the thymus, a patient we treated thymus neuroendocrine cancer, very aggressive, really cancer, not neoplasm. Okay, one strictly should differentiate between that and that neuroendocrine prostate cancer, which is a completely different type of neuroendocrine than we usually see in the bowel or in the pancreas. And we also had a patient actually with atypical lung carcinoid, also a very aggressive type of tumor. And we get very good images with lutetium and SPECT-CT using FAP. And what I want to point out again here is a very low uptake in the kidneys. So the kidney have not higher uptakes than the surrounding tissue with this. And with that, I want to end and invite you actually to the next Theranostic Congress, which was planned last year in Chile, but unfortunately Corona, crossed it out, and we will have the meeting in a few days from now, end of June in Wiesbaden. And I would like to point out that you can still register free of cost for patients. So we have a 2-hour session planned there with a patient panel and a physician's panel and a lot of discussions. And Dr. Simron is participating also in the meeting, and I look forward to all of you. So if you are interested, just go to this website, twc-2020.org, and you can register free, also virtually, so it's a hybrid congress. You need not to be there in person, so we will have a lot of patients being there. Josh is leading the session and the discussions. Thank you very much for your attention.
So thank you for that brief but exhaustive overview of PRT and a little bit of what the futures might hold. Let's see if I can do this correctly. We've generated about 16 questions online, and I'd like to bring this to you oh, that's right, you guys can't see this, right? So I'll read them as you, one of the things that we're certainly facing as we look at different clinical trials in the US and other things that are coming up, how does a patient choose between different options, whether it is using a registered product, going on, Dr. Singh, you mentioned some of the trials that are coming up from the NCI. Dr. Baum, you've certainly talked about some of the alpha trials that are coming up. How does a patient choose between going on to a trial or using conventional therapy at this point? I'll let Richard, you can talk first. And
I think it's quite easy. You should start. Is that on?
no,
Yeah.
not really.
Okay. Okay, yeah. So I think the answer is quite easy, because you should start with what is approved, because this has evidence from clinical trials. And in, I would say, 95 or 98% of cases, you could really start with lutetium dotatate or dodatoc, what you prefer. I prefer actually personally dodatoc still over dotatate. But only if there is no response, or if there is a specific situation, you should go on with more experimental therapies, because all alphas are not approved, right? They are not regularly available, even not for me. So we have the supplier in Munich. ITM is, delivering actinium, but only twice a month, so it's very limited. And I think we need more capacity for production of these alpha emitters. The same is true for lead, right? Lead-212 is a generator product, and these generators are not commercially available. They are still research. And I think, of course, one wants only the best. If I would be the patient, I also would look for the best to get. But sometimes it's just not available, or only for research available. So go with lutetium dotatate. That's approved, right? And the only thing I would like to add is that there are not only 4 cycles to be given, right? We have just treated, before I left Wiesbaden and come to the conference here, a patient with 15 cycles of PRT, quite young, and without any significant adverse effects, right, after 15 cycles. So it's not that you have a limit given by the kidney or by your blood counts. You just have to check if the system still has capacity, to take another treatment, and then you go on, right?
Simran, you want to add?
Yeah, I think it's a great question, and I completely agree with Dr. Baum. I think, lutetium remains our mainstay of treatment. I think, it's always good to explore clinical trials, but if you're going to be looking at, I think the question was about alpha versus beta. Alpha therapy at this point has not been shown. We don't completely understand, although there's data emerging. It's not standard of care right now, so if you are considering that, you may want to consider, if a clinical trial is available, to consider if that's the right option for you. But lutetium remains our mainstay of treatment. In terms of the retreatment part, I should also mention, we are examining that as well, and patients in at least North America will have hopefully the opportunity of looking at retreatment in a clinical trial and at retreatment in a clinical trial, which will hopefully continue to build on that experience that Dr. Baum is describing of being able to go beyond 4 doses.
So I think one of the questions that patients often have is the risk that they have for undergoing therapy. And one of them is, MDS and possibly AML as one goes forward in time and with different treatments that happen. So first of all, is there a difference between what we have conventionally, Lutathera or PRT with a beta versus an alpha as far as what that might mean for MDS possibilities?
The answer is just we do not have the data, right? I mean, I'm treating patients with actinium since 2016, so 6 years, right? And most of the patients receiving alpha emitters were far advanced cancer patients, dying after some months or years. In the cohort of PSMA treated patients with prostate cancer, we have not seen any single case of MDS up to now. So we have done a lot of what we call tandem treatments, combining actinium and lutetium. And in the cohort of neuroendocrine tumor patients, we have published the largest series in the world with over 4,000 treatment cycles over 18 years, and we found a rate of 1.6% of MDS. And many of these patients have received, in addition, previous chemotherapy or capecitabine and other drugs which are also known to cause MDS. So I think the rate is relatively low, definitely below 3% overall of MDS, and if you look at chemotherapy, you know that better than me. The rate is quite similar. If you are using alkylating agents, it is more than 5%. If you are using streptozotocin, there are small series showing it's more than 10%. So overall, I would say, lutetium radiopeptide therapy has the same or even less risk than alkylating chemotherapy, right?
So, you want to?
Well, I definitely don't have as extensive experience as Dr. Baum, but as a radiation oncologist, I do find that the time to developing MDS, AML is a lot shorter than radiation exposure with external beam. Recent conversations with our colleagues in the leukemia field, there's now some genetic signatures, that would predict people who might develop it, and I think collaborations to screen patients for these signatures and how they evolve will be the way to go forward.
I think you made a very, very important point. It's not so much the radiation, if it is external or internal, or if it is chemotherapy, it's really the genetic status of the patient and the predisposition. That means, if something hits the DNA, there are patients who can repair this DNA damage, also in normal cells, very well, whereas other patients, have some deficiency in DNA repair genes, and these are really proposed to get the MDS and so on. I think it doesn't matter what you use, if you use external or internal or chemotherapy. So yes, we have to do in future, I think, have a closer look, to the risk of those patients, which would probably lead to a different decision if there are other therapies available.
So going on real quick, Dr. Wang, you brought up the guidelines for using somatostatin analog imaging. And so, you know, we're asked this question a lot. Is there any specific, how often should a dotatate scan be given? And I know, Dr. Singh, in your practice as well, for surveillance, so how do you use the guidelines for somatostatin analog imaging, and how do you request scans in general for that?
I'll just start. In Ontario, it's easy because the government specifies it for us, and show that chart with the with the criteria. But I think that the key is really whether it will make a difference to the decision making. So if by doing the PET scan, I'm planning to do surgery, I'm planning to start PRT, I'm planning to withhold treatment, doing that PET scan would change how I'm going to do it. Usually we can make a case to get it approved. Same goes for Fdg, it requires special approval.
Just let me mention, I totally disagree with the point you made on the follow-up and saying, you know, it has no more values than CT scanning in the follow-up, which is complete nonsense, excuse me, right? I mean, with CT, you are not really looking at bone. Of course, if you have osteolytic lesions and so on, you might see it, but you miss 90% or so of bone metastases you see on the PET scan. And I think, of course, one need not to do every 4 months or 6 months a PET scan. I agree on that with you, right? One can use cross-sectional imaging, you know, like ultrasound, for example, which is very easy to do, or MRI, you know, for the liver and so on. But if there is a question, one should always use, or in a certain time frame, I would say maybe 12, 15 months, one should have a PET scan just to look, you know, what is the extent of the disease. Because you totally underestimate the extent of disease when you are just using CT, right? And the meta-analysis you cited is idiotic. That's why it was published in Clinical Nuclear Medicine and not in a renowned journal, right? Because they just looked at very, very early trials, you know, where there was no quantitative PET, there was no PET-CT, right? And all these things, you know, just reading points on an image and saying this is progression or not, that's not how we do nuclear medicine nowadays. You have to do it quantitative. You have to determine, you know, the molecular tumor volume and all these things, you know, and not read gallium images like Fdg images, which is still frequently done around the world. I know that because I have patients from all around the world. And you get gallium report, which are, you know, a template of the Fdg. And then sometimes they even forget to delete Fdg, and there is Fdg mentioned in the report. So please do it quantitatively, right? Do it state of the art, and then you will see it has a significant value above just CT. I love CT, right? And it's very important, but, you know, to get the extent of the disease, you need to do, you know, somatostatin receptor imaging.
So I just might add in here, I think, you know, this is an important debate, but what is also, you know, in Canada and in Ontario, as Dr. Wong said, I mean, we have a publicly funded healthcare system, and the decision is somewhat made for us. The way to sort of continue to move forward is to, as you said, Dr. Ram, is to continue to build that evidence and to continue to build the data so that we can understand more and more what the roles may be. We can open up the scope of that. We can move forward in understanding, you know, where this new imaging can come into place, where future imaging can come into place. And, you know, as, again, then it's a plug for, like, we should be doing research together to be able to build the data so that we do have the reimbursement and the ability to do it. Because, you know, as you said, there could be very valid reasons to do it. We just have to build the data. The other thing that I thought was really interesting about what you said, and I think what we're seeing even here, is the importance of multidisciplinary collaboration. So we're learning from the nuclear medicine and our colleagues at home as well, from the nuclear medicine departments about how that may look. We're learning from the radiation oncology departments about what what their aspects they can bring to neuroendocrine care from medical oncology, from the surgeons. So this discussion actually just points out how important it is to have multidisciplinary care, because everybody's input is important to be able to provide the best person-centered care.
So I think the next set of questions actually have to do with that concept of we need to do studies to get answers. Is there a consensus on radiosensitizing medications, or what seems to hold the most promise? And I know last week at ASCO we just had, and I believe you brought up I think Dr. Singh, you brought up the ControlNet trial in Australia that was trying to get there. I think they, on the PNET side, said we need to do more studies, if I remember correctly. And then also current active trials on PARP inhibitors with PRT, I know that are ongoing in different areas. Do you want to comment on either ControlNet or the NIH PARP trial?
Well, maybe I'll start just from there, and then I'll pass it off. But I mean, especially on the PARP inhibitors, I think that's obviously going to be an exciting new area. We do have 2 ECTN trials now, smaller trials that are going to be reported very soon, and hopefully once we see the results of those, we can move to larger trials, which I think having combination therapy would be used. In terms of radiosensitizing medications for PRT, I think I'd probably leave that to Dr. Baum and Dr. Wong to comment on. They probably have more experience than that.
Yeah. Again, this is really an area of clinical trials, or even, compassionate use in some patients. So there is no systematic trial comparing, in the patient cohorts, different radiosensitizers and so on. We are using a very interesting agent which is called BOT, benfoxytiamine, which is a thiamine antagonist, so vitamin antagonist, which is actually necessary for the transcatolase pathway, so we can inhibit the repair capacity of the cells. That was very convincingly shown in preclinical trials, but there are no real systematic studies, no randomized trials on that, and just limited experience, right? So we are using it, but again, more in patients where, all other methods have failed and so on, and one should not just use it because it might be better. That's my comment on that, right?
I don't have any systemic agent that is not on study that I would suggest. I think an area that is very interesting is the synergy of external beam radiotherapy and PRT, and the potential for abscopal effects. I think those are the areas that we could really capitalize on the synergy.
Again, one also have to look at the patient population, right? If you have let's say G3 tumor with a higher proliferation rate, let's say 25-30% G3 well differentiated, then you can think about CAPTEM or other radiosensitizers which have proven value, I think. But if you are looking at the typical, slowly growing G1, G2 neuroendocrine tumor, for me it makes really no sense to give CAPTEM, for example.
I mean, I think it's also when we're thinking about combination therapy, we're looking at both the benefit as well as the risk of toxicity. As we mentioned, I think Dr. Baum and Dr. Wong both pointed out that it's really a pathway that probably involves DNA damage repair that causes the long-term toxicity, or the AML and MDS. So combining an alkylating agent with PRT can potentially accelerate that process in terms of DNA damage repair. The other area that Rebecca brought up that it also reminded me is immunotherapy. So from a medical oncology point of view, immunotherapy has not been a successful story in neuroendocrine cancers, unfortunately. And I have to say, I look at somewhat jealously upon my colleagues who are able to use it in lung cancer and melanoma with really good results, and we haven't been able to. The hope would be that maybe, as you described the abscopal effect, maybe immunotherapy and PRT, bringing those two together will actually build synergy that we'll be able to sort of see our neuroendocrine patients benefit from immunotherapy like so many other cancer patients are. So that's another potential area for combination that hopefully we'll see more and more movement in the future. I know there's a study right now at UCSF that, again, is a smaller study, but will give us some preliminary data to help us understand if we can move forward in that area.
If I may,
You
I
may.
do want to go back to the issue of the PET. I'm just thinking about for the patients that you talked about, especially in Canada, in Ontario, the thought of if we truly believe that there is evidence that PET should be a surveillance tool, then the enabling evidence should be incorporated into guidelines and change the policy so that it is available. I think it will be disadvantage to our patients if we put forward that it should be done, but it's not available.
I'm going to kind of combine a few questions here as we're running a little short of time, but not too badly. One of the things that often patients ask about is either dose modifications for PRT, or given a fair amount of liver burden or even some kidney damage coming into PRT, if they should be dose modified, or other things that might impact using it for different things like bone mets and things like that. So how do you go about dose modification, and does it change with intraarterial administration, which I know is not something that is often done, and doesn't have a lot of phase 2 trials on it?
Maybe you can personally better ask this than me. So I did the therapy and you were the patient. Yeah, I mean, intraarterial is something we really consider mostly in patients with a high tumor load in the liver, right? So big metastases, and then preferentially using yttrium-90 because it's a harder beta emitter, or even alpha if it is available. And for bone metastases, I would say there is really no change from the standard. So there is no, I stress, no bone marrow toxicity from lutetium, right? You can treat patients, for example, with prostate cancer lighting up like a Christmas tree with hundreds of metastases down to the fingertips, right? You can treat with lutetium and there is no increased bone marrow toxicity. What we are seeing is that if there is progression in the bone marrow under the treatment, then there is worsening of blood counts, platelets, and so on. But this is progression of the disease and not an adverse effect of PRT or PRLT, PSMA radioligand therapy, which in some patients, even the counts are improving. I just had a patient, with widespread bone metastases, where after lutetium treatment and even after actinium treatment, the counts are improving. So I think there is no toxicity there. And there was one question, I think, which is very important. If you should give denosumab or, for example, biphosphonates in patients, I think yes, I think you agree, especially if there are osteolytic metastases. So if the metastases are eating up the bone, if there are osteoblastic metastases, so is there more bone formation, one have to think carefully if one gives this or not, because although these agents rarely have some quite devastating side effects, for example, osteonecrosis in mandibular and so on.
So I'm going to kind of ask two more radiology questions. So let me get this one out of the way here real quick. So I'll do the first ones first. We've actually done, as part of our support group, how to read or how to understand your radiology report. In the US, and this may be different in Canada, we have now a law that requires the narrative to be released as soon as it's available, which has caused some challenges as well, and work for education. So how do we have these reports be easier for patients to understand, one? And the second one is kind of, the second question here is, a patient who either has an MRI or a PET scan and it doesn't necessarily match to their MRI, and how do they interpret that? And you can take either one first, and after that we're going to close the session, and there might be some time for people in the audience to come up and visit before I take people on an exhibit hall tour.
I just want to, I'm going to comment on the first one, Josh, about the
Sure.
radiologist and then making it. So I think this is it's actually a very important point. And part of it is, as you mentioned, you know, it's not legislated in Canada, but we do see a big growth in patient portals. And this is a changing role, like kind of what I talked about how care isn't episodic anymore. People don't come and get their scan and then wait 4 weeks for the results. It's a continuous, living with cancer and living with neuroendocrine is a continuous journey. And so our system has to change and model accordingly. And a big part of that has been introduction to patient portals where patient can log in and start to get their own information. But as you know, and it's a learning curve, right? And as we're realizing that, we are realizing that we also have to make the information patient-facing. So a couple things would be, you know, we have to start, and there has been discussions about this, about, you know, taking the clinical data and being put in a patient-facing way that can be accessible to patients. But I think part of it is also patients engaging in their care overall and continuing to have these discussions and meet with, you know, have discussions about where things are going and understanding their scans. And I think that it's a big change from where it was before. And I think especially with neuroendocrine, it's very important that patients continue to be engaged in their care, have these discussions, have these conversations, and this is all part of that larger theme.
So interestingly enough, as part of this, we've asked patients how would they prefer to receive their imaging report, and the results are sitting right up there for you to look at.
Yeah, I mean, and so I think that's understandable, right? I mean, we're also learning how do we communicate with patients outside of clinic. I mean, you know, there's like asynchronous communication. How do we build these models, respecting privacy, respecting the realities of our healthcare system, but allowing, you know, some sort of ongoing communication between visits, let's say. So these are all, I think, challenges for our health system to be able to build up towards in a bit more of a person-centered care fashion. Yeah.
And if you allow, I would really like what you stressed is really a multidisciplinary approach. And the different disciplines, and there are always different disciplines involved in neuroendocrine tumor patients, really have to communicate better with each other, right? So the one question was, my MR report showed something different.
Right there.
That happens so often, right? And if you just take the phone and phone your colleague, you know, why there's some differences between my findings and your findings, and you see the images together, you solve it. And then you should speak to the patient, and then you should write your report, and not separate without talking to each other. So I think this multidisciplinary, and I think I founded the second ENET Center of Excellence in Germany, right, where there is a requirement, you know, that you have a pathologist in the tumor board, that you have a radiologist, that you have a radiation therapist in the tumor board, that you have an oncologist, a gastroenterologist, and so on. And this is audited. It's not just saying, oh, you have to. It is checked. Were they there? Did they give their comments? You know, were there protocols? And this is what we really need to improve care, right? We really need multidisciplinary teams taking care of the patients, and that in a structured and documented way.
So Dr. Wang, I will give you the final word for the session, so please go forward.
I just want to say that I understand the frustration, and as has been said, the way we handle it clinically is actually bring the case to tumor boards, have the radiologist there, make sure I have all the images available, and get them to interpret it with the information as when treatment has been given. Sometimes the clinicians on our end is not provided the relevant information to make it easy for the radiologist. And I guess finally, I think the power of our patient advocate is really important. And I like to tell the story that Ontario was able to do our PRT trial, I think for the most part because of patient advocacy. And I think synoptic report actually had just requested, discussed in our site group, can't our radiologists give us a synoptic report? I think Sunnybrook actually have the synoptic report. So I think having those type of policy and perhaps with support from our patient advocate that they want to see that too is very powerful.
And with that, I'd like to thank all three of you. I'd like to thank Denny for sharing his story with us, and thank CNETS Canada, thank the Parapheo Alliance that's here as well, PanCan, who is also our host for this session as well. For those of you who registered for in-person or online for this, you will be getting a survey in the next few days. Please fill that out so we can get some feedback on how we did. I hope you enjoyed this. Those of you who are here, and there are only a few patients around and who would like to have an exhibit hall tour with me, let me know and we'll start up probably in about 5 minutes. For those of you who want to come up and thank our speakers and say hello, please feel free. And with that, this session is officially closed.